Breathing the plume or the smoke that you see come off of a patient is like inhaling body parts and whatever that patient has. And there have been so many studies over the years. AORN's guideline on surgical smoke has over, I think, about 225 peer-reviewed articles that document what is in the smoke, what it causes, what some of the symptoms are, and then what we need to do to protect ourselves. We're protecting ourselves and our patients. It's not just us, but whoever's in that room is protected when we take the time to use a smoke evacuator and an appropriate filtration system.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On this week's episode of First Case, we are speaking with Brenda Ulmer, independent perioperative nurse educator. And while we have hinted at the topic of surgical smoke throughout the entire season of interviews that we've done so far, today we're actually going to be talking about it. And we're going to talk about the dangers of surgical smoke, what it even is, and why we should be pushing for surgical smoke evacuation. But Chris, you've got an interesting fact that really helps out the point of this. So share it with us.
So I was so excited about this interview with Brenda because as a surgical tech, I am one of the first people to breathe in this plume that can be so dangerous. We're so close. And I looked, so William Bovee, he was a PhD and he created the ESU, which is what we lovingly refer to as the Bovee, in 1920. And then Dr. Cushing used the ESU for the very first time in surgery in 1928. We have been breathing in God knows what since the 1920s.
For almost 100 years. I mean, if you do
almost
the math.
100 years. And if there's not a time for some legislation and education on the dangers, gosh, now is it. So I'm very excited we're interviewing.
Definitely. Now is definitely the time to be talking about it and pushing to protect ourselves and our patients from surgical smoke. So don't go anywhere. We will be right back with Brenda Ulmer.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Brenda Ulmer, independent perioperative nurse educator and passionate surgical smoke evacuation advocate. And today we are going to dive into the topic of surgical smoke and smoke evacuation. But before I get too far ahead of myself, Brenda, thank you so much for being here on the show with us today.
You are welcome. Glad to be here.
Oh, gosh, I'm so excited to have this conversation. Each of our interviews that we have done has kind of hinted at surgical smoke in one way or another, just because it's such a huge topic, and advocacy for that has been so prevalent right now as everyone is moving to try to get legislation in their state. And now to just have an episode dedicated to it is so exciting. But before we really get into that, why don't you go ahead and just introduce yourself to our audience and tell them a little bit about who you are.
Well, I am a longtime operating room nurse. I went to work in the operating room right out of nursing school, and it was the only place I ever wanted to work, and stayed in hospitals for a number of years, then took a job as a perioperative nurse educator for a medical manufacturer, and have done various things throughout my career, serving on AORN's board of directors and then as AORN president 2000-2001.
Awesome. A jack of all trades, if you will.
Yeah, absolutely.
Yes, Brenda. Yeah, I love that.
There have been some themes weaving throughout it, though. Patient safety is one, and how the nurse connects with the patient and how important that is another piece of it that is high on my list of things that are so necessary for us as perioperative nurses.
Absolutely.
Well, and I think not just that, but you're a huge advocate for the surgical team. So those of us who are surgical technologists, and then the other, the circulating nurses in the room, a lot of what your work has resulted in is not just advocating for those patients, but making sure that that team taking care of them is also taken care of. And I really applaud you for that.
Oh, well, thank you. It takes all of us working together to get that patient in and out and make sure we're healthy too, because we can't provide good care if we're not taking care of ourselves as well.
That's such a good point. I think we can be our own worst enemy in that. I mean, I'm totally speaking for myself there, but yeah, we can run ourselves ragged and, put the patient first instead of the team. And sometimes that results in some negative effects on us. And surgical smoke is definitely a part of that.
I agree. Yeah. The bad thing about surgical smoke is in most people, it takes so long to start experiencing symptoms of breathing smoke for so long. So the gap between when you get exposed and how long you're exposed and then actually have symptoms is part of the reason that it's taken so long to begin to see some action with smoke evacuation, which is what we should be doing, and filtration.
No, absolutely. I think we see that in other issues too, where it's one of these time delayed things. And since people don't necessarily see that there's been an effect right now, or they have to look back for so long to see that it's been a cumulative effect, that they have trouble making that correlation. And so educating them and telling them the problems with like surgical smoke in this instance really helps them see that, no, this is a problem. It is causing these things. It just takes time for it to show up. Brenda, I heard you give a presentation in 2022 at the Georgia Council of Perioperative Nurses. And that was the first time I heard your story and I heard you talk about surgical smoke, and you really dove into the dangers and all of the things. And I really want to share a lot of that information with our audience today. So I'd really like to just start at the beginning. Like, what is surgical smoke? If somebody listening does not exactly know what it is, or they are unsure, let's just start at the first part and just explain it so that they have a good understanding of what we're talking about.
Well, surgical smoke is the result of burning human tissue. And over the years, I've heard people relate smoke to being the same as a barbecue or burning leaves and things like that out in the yard. That is not the case. Whenever the surgeon activates the electrosurgery pencil, it produces a plume made up of whatever is in that patient. So toluene, benzene, formaldehyde are some of the gases. And we wear masks, and some people use a suction, and masks do help. But with the gases that we've been breathing for all those years, benzene is a known carcinogen. It's a known trigger for leukemia, and there are tons of papers on that. We've never been able to adequately protect ourselves from the gases, from the particulate matter to some extent, but the gases still get through even an N95. So evacuating and filtering that smoke is really the only way to take care of it. What happens in the smoke evacuator is that there's a carbon filter on the inside of that smoke evacuator, and it locks up those gases. So they're not being released out the smoke evacuator. So breathing the plume or the smoke that you see come off of a patient is like inhaling body parts and whatever that patient has. And there have been so many studies over the years. AORN's guideline on surgical smoke has over, I think, about 225 peer-reviewed articles that document what is in the smoke, what it causes, what some of the symptoms are, and then what we need to do to protect ourselves. We're protecting ourselves and our patients. It's not just us, but whoever's in that room is protected when we take the time to use a smoke evacuator and an appropriate filtration system.
I think you hit on why it's dangerous and what it can do to us. But one of the questions I think I have is, we have policies and things on laser and eye protection for everyone in the room. We have policies on, so many other areas. Why do you think there is such a battle for getting and maintaining those policies for smoke evacuation? And I know legislatively it's a long process, but why do you think we don't have stronger policies within our hospital systems about it?
Well, part of the reason is what I said earlier about the length of time it takes to actually experience the symptoms. And I stopped working full-time in the operating room in 1990. I still was working part-time. And I was diagnosed in 2010 for adult onset asthma. And I went through a period where it was just respiratory, just one thing after another. And what my general practitioner said is that I had a 90-day cough. And that didn't make any sense to me. I had to go to an allergist who said, you have asthma, adult onset asthma. And there's nobody in my family that has asthma. I don't have a family history of that. So for me to go back and link my symptoms and what I experience now with my work environment for so many years it was like an aha moment when I finally realized it. And I don't know, Melanie, if I told the story, but I didn't really get on the smoke evacuation bandwagon until 1996 when I was in my master's program. And my instructor said for my capstone project that I needed to do something related to my job. And I thought about it and I said, I'll do it on smoke. And that's when I started doing the research. And during that period of time, 96, I was also on ARN's board. So I was working like a full shift once a month. And I went into the operating room one day when I hadn't worked for about a month and at full smoke producing cases all day long. And when I was walking to my car that day, my nose burned, my throat burned, my chest felt tight, and I felt sick at my stomach. And I remember distinctly thinking, I'm getting the flu. So I went home and didn't think anything more about it, felt fine the next morning. And then went another month or so and didn't work in the operating room. And the same thing happened again. And it was about that point when I made the connection that when I'm not working every day in the operating room, my body tries to get back to normal. It tries to get back to that state that, where I haven't been breathing smoke. So then when I go back to work in the operating room, I get the full force of breathing that smoke for a number of hours a day. And that's when I became a real advocate for smoke evacuation and filtration, because what I had experienced, and it was only 20 years later in 2010 that I learned that I now have asthma, which is, I'll have to deal with that for the rest of my life. So the message to people now is that take care of yourself. So when you are older, when your body is more compromised because of age, that you don't have that added burden of a very reactive airway that keeps you sick and on antibiotics and steroids and all of those things. So it's part of taking care of yourself.
My husband says constantly, like we try to tell our kids all the time, make future Chris like past Chris, take care of future Chris. I'm not very good at doing that. And I think it's true. We have to do the things now in a preventive stance in order to make sure that we aren't, a part of the hospital system and the medical care system as a patient, as opposed to a caregiver.
Oh, yeah.
Yeah. So it's interesting, though, that you said that you would work a month or go a month with a break, and then you would work a shift, and then you would have to recover from that shift, and then it would take about a month, and then you would go back to work again. And, ALRN's recent information says that working a shift in the operating room with all of those smoke producing cases is like the equivalent to smoking 27 to 30 cigarettes a day. And so you think about that exposure on your lungs and that work, I guess, of your lungs trying to clear all of that. I can see how you might leave feeling like you had the flu. And then for those of us who are working full time, so we're in the OR every single day or 312s or whatever, we almost, I think, get used to that feeling because we don't realize that we feel that way because we're experiencing it every single day. And it takes getting out of it regularly and then going back in before we realize, oh, this is actually a problem and it is affecting me. I don't think everybody realizes they're affected because they're so exposed to it every day. Do you think that's right?
No, I absolutely think that's right. And it's like people who smoke cigarettes. As long as you're smoking cigarettes every day, you can't feel what it's doing to your body. But when you try to quit smoking and then go back and smoke again, I mean, it's like an explosion in your head of introducing those carcinogens into your body. So no, I think that point is absolutely correct. When you're in it every day, you don't feel it. It's only when you're away from it and then go back to it that you can actually feel what it's doing to you.
Recognize it. Yeah.
I was just curious, like throughout this process, I'm sure you've shared your story with so many people and your symptoms. And are you finding similarities in, how other people that are in the operating room are experiencing the effects of the surgical plume?
There's some documented literature on that. Kay Ball did a study in 2010 and did it again in, was it 2020 or 22 was when she replicated that same study. And nurses are more prone to respiratory illnesses than other people. There's also a Reuters publication about how nurses are twice as likely to experience those. But it's different for every single person just because of the random way that whatever's in the smoke is released into your body, because you inhale the smoke, it goes to your lungs. The tiny little particles and the gases get down into the gas exchange regions of your lung, attaches to red blood cell, and then wherever that oxygenated blood drops its load of oxygen is random. It could be years before you experience any ill effects just because of the random way that oxygen is introduced into your body. But it's cumulative, and the years of breathing smoke are what really makes a difference with people.
Okay, so before we move to talking about your advocacy story with the state of Georgia, I actually have one practice question that I want to address with you first, because this is something that I see time and time again. When I would scrub in and do total joints, I would be the one holding the yank hour, suctioning away the smoke. And it was right. I mean, it wasn't going into my hood. It wasn't getting in my face. I couldn't necessarily smell it as badly because it was being suctioned away. But that's not actually doing any good, is it?
No. All it's doing is moving the smoke from one part of the room to another part of the room. And it gets the load of particles in the room accelerates rapidly. And so when you're suctioning, I mean, some of it will go into the suction system, but it's still not an adequate filter, the carbon filter that binds to the gases and things. And there are papers published that have pictures of hospital filtration systems where that smoke is accumulated. And there's one study where they tested it for blood, and even, where the outflow vents are in operating rooms. I mean, that's a good distance away from most surgical tables, but there were different levels of blood found in each of those outflow systems that they looked at with this particular paper. So evidence of all kinds of things all over the operating room for years past. I mean, we've got lots of data.
Yeah. And it's terrifying to think that you think you're at least doing something by suctioning it away, and you're really not. You're just making the problem worse, and then also exposing other parts of the facility and damaging your air intake and all this other stuff, which it makes it surprising to me with all of the research that's out there. I mean, we've known since 1980 that surgical smoke was a risk. And
1977, Mahashi was one of the first articles.
That's okay. Yes. So yes, so we've known for a very long time. I was thinking of a different article from 1980, but okay, even 1977, that's older than me. So we've known for a very long time that this stuff is risky, and we've just continued to learn more about it, and its research has continued to show that it is even worse. And yet OSHA does not make a specific legislation about it nationwide. And so it has fallen to the states to pass legislation. And so that's really what we want to hear from you today is how did you get legislation passed in Georgia? Can you tell us your story?
Oh, it's a long one. Well, OSHA thinks to go talk about the OSHA thing. They think that they already have laws, legal talk on the book that addresses surgical smoke. And OSHA is a political organization. Their head is appointed. And so every time the administration changes, the focus of OSHA changes as well. But they think it's already covered on the books. I decided in Georgia to go for state legislation only after Colorado and Rhode Island had already done it. And in 2019 in Nashville at ARN Congress, we were talking about what had happened in Colorado, what had happened in Rhode Island. And I came home and I thought, you know what? We need to be the next state to do that. And so we started here in Georgia. In 2019, I called the Georgia Council chairman at that time and I said, this needs to be a focus for Georgia Council. And she said, well, we need somebody to head that up. Why don't you do that?
That's usually how it goes.
I know, that was Pat Thornton. So we started and we had a small group and we started calling legislators and sending letters and organizing throughout the state. And there were 3 or 4 of us that traveled to different chapters all over the state. And what we were trying to do was educate our members on what the dangers of surgical smoke were and introduce them to the concept that we're not just nurses or technicians. And the AST in Georgia they were our partner from the very beginning. Every time we had testimony, AST was right there with us. So
that's awesome.
I have a good friend of mine that's on the Georgia board.
Oh, who is that?
TC Parker.
Oh, yeah, she was there. I mean,
TC Parker is a mentor of mine. Shout out to TC.
She's
love that woman. But I hear so much of your passion in her and hers and yours. And that's what it takes, right? A combined voices. Melanie and I have this conversation all the time about unity and collaboration. And it really takes that to be able to get these big things done. So I love that you all were able to work together on that.
Yeah. And we're still, I saw one of the AST people at Georgia Council meeting a couple of years ago, and they have an issue now too. And I said, go to our lobbyist because they are the part of the group that helped guide us through seeking legislation in Georgia. So it is not easy. It is consistent work for most people over a period of time. Some states have done it in one legislative session. Ours took 3 years. That's not uncommon. California took from 2016 to this year to actually get to the point where they're going to have laws on the books. So it's different in every single state, and it depends on the legislator and how they approach it and what their skills are legislatively, to be quite honest with you.
What kind of hurdles did you encounter as you were going through this process? I'd like to know what difficulties there were.
There were a lot of difficulties. Well, one of the hardest things in the beginning was just getting a meeting with our legislators. And I initially tried to contact my own, and Gloria Butler's her name in Georgia. And I called her office so much and left messages and sent her materials, and her secretary, when I would call and said, oh yeah, I gave her the message. And that happened consistently. The state legislators have their plates full too. And what I found out is that the state legislators are interacting with the people that they have the most to do with. Lobbyists are one of those groups, and they're getting lobbied by people for whatever their special interest is all of the time. And it goes, like in Georgia, it goes from fish and game all the way down to numerous other things. And how do you make the case that the smoke evacuation is more important than what's going on in the cornfields. So that was establishing the dialogue, getting to people, having access to the people. One of our legislators was a surgeon, and she was not chair of the Senate Health and Human Services Committee, but she was very close to the chair. She was a hand surgeon. And in one of our testimonies, she got up and testified that she did surgery for X number of years and she never produced any smoke.
What?
I swear. No, she said it. It's on tape in the Georgia record.
Wow.
And I'm going, well, let's see now. You operated on the hand. You exsanguinated the limb. So you weren't producing any blood. And, oh, yeah, you didn't use well, one of her scrub nurses or scrub techs came up to me who scrubbed with her all the time. And she says, I just want you to know she did produce smoke. And this person went to this legislator. They went to the same church, and she went up to talk to her about this specifically. And she said the legislator never spoke to her again because she had contradicted what she'd said. And
that's not good.
That's part of the problem. We had a surgeon in Georgia who high up, he did small surgery, but he also said that, he had been a surgeon for X number of years, not as long as I've been in the operating room, and that if anybody should be concerned about smoke, it was him. He didn't think there was enough data, and he leveled the charge that smoke evacuation was being pushed by the manufacturers just to sell their equipment. The Georgia Hospital Association also adopted that position. They didn't want to have to deal with it. So it was constantly battling those kinds of, and if you say something like you're getting money from a manufacturer to push this, that sort of just stays forever.
Yep.
Even though it's not true.
No, I have heard that from multiple people that I've been told that. Also, you mentioned Kay Ball earlier when you were talking about her, and we interviewed her for this season as well. But when she was talking about surgical smoke, she said that, I think it was Kay anyway, she said that a surgeon testified that surgical smoke was like the smell of success or something like that, and there was nothing else to it. And I'm just blown away that that's the idea, that there's nothing wrong with it, that it's totally okay, and it's not a danger. That just amazes me that people.
Well, it does amaze me too, but the thing in my mind, it's cumulative. The effects are cumulative, and most surgeons, some are in the operating room every day for many hours a day, but most have certain surgery days. They come and go. They're not in there as many hours as nurses and technicians and other anesthesiologists. We have continuous exposure throughout the work day. The surgeon comes and goes. So, no, I respect surgeons a lot, and I love surgeons, and I loved working with surgeons. What I am seeing with the younger guys that you come in contact with now is they're more open to protecting themselves than some of the older guys are. So it's different for every person, and you can't take one person's experience and say it's going to be the same across the board for everybody. It's just not that way.
Well, and I would think that you're having obstacles talking to people who speak our language and who operate in our same environments. And then to also be able to translate that to non-medical people who don't have a clue, I think that would be a huge hurdle to kind of decipher what it is that we're talking about, and also like how dangerous it can be.
We didn't get smoke evacuation passed in our first year, 2020, but we did get a Senate study committee. And so that was 3 2-hour sessions with all of the representatives where we were allowed to bring in people to testify. And one of our most impactful people was Angela Hohn, who was a VA nurse and was diagnosed in March of 2020 with lung cancer. And so she had been throughout that whole treatment area of trying to determine what was wrong with her. And her general practitioner told her later on that she thought her cancer was from breathing surgical smoke for all of those years. So Angela's testimony was so powerful. And that's one of the things that is so important for all of us is to tell our story, because it has an impact on people who are not in the operating room every single day. And somebody that I know had come in for something at the Capitol. I don't remember what it was. It's 2020. And they had been in a cab ride between downtown and the airport. And so the person got in a conversation with the cab driver, and they said they were there to talk about surgical smoke. And the cab driver said, I heard about that. They should not have to breathe that surgical smoke. So
Wow.
it got out to the general public.
Oh my gosh, that's
cool.
amazing. We can't get the general public to know what a surgical technologist is. And
Yeah.
Video cab driver, that's amazing.
Well, we had 3 or 4 segments on the local news, and that again was part of the networking. I mean, we reached out to all of our people in the state of Georgia, and people know people. So we had a nurse who knew this newscaster and another one who knew this other newscaster, and we contacted them and they agreed to do the news stories on it.
That's awesome.
So
That's a
yeah,
good idea.
it was good.
Wow. So right now, at the time of recording this anyway, there are 15 states that have surgical smoke evacuation legislation, which means there are quite a few states who don't. So if you wanted to give some advice to anyone in these states that don't currently have surgical smoke evacuation, what advice would you give them to get started so that they could work on protecting everyone in their state from surgical smoke?
Well, one of the first things that I would recommend is that the person educate themselves on what the dangers are of surgical smoke. Once you get that piece in your mind and you really believe that it is dangerous for patients and for perioperative personnel, then find out about the political system in your state. Educate yourself about who's in power, who do you need to contact, who do you need to work through to navigate through that political system. And it is a navigation. So just educate yourself about the dangers of surgical smoke, find out who your advocates are, partner with your different nursing organizations within your state. And like Alabama only has 2 ARN groups. However, there's lots of hospitals. So it'll be a little bit harder, more work is what it is to access those hospitals, but you can do that. And through ARN, and ARN is a wonderful advocate for beginning the steps that you need to do to seek legislation in a particular state. ARN has the ability to, even without different chapters all around the state, to look at each individual legislator and accumulate a list of nurses who live in that legislator's voting district. Because
Oh, wow.
with politicians, the only thing they care, I don't mean to denigrate politicians at all, but they don't want to hear from me in Alabama. They want to hear from somebody who lives in Alabama. And even in the state of Georgia, the legislators in Georgia wanted to speak to me if I voted for them or if I lived in their voting district. And if I don't live in their voting district, they want to talk to the people that are going to actually help them get reelected. So that's the reason the network is so important, is because somebody knows somebody. And on Florida now, there's a lady in Florida who's working on getting legislation in Florida for 2024. She has a nephew who is an anesthesiologist at one of the big hospitals down there. And I said, there you go. I mean,
it's a small world.
It's a small world. So many people know people, and just find out who your advocates are, who can help you, and who is willing to take the step to try to help you find out what you need to do, and then actually help you with the tools to be able to do it. And I mean, I tell people when I talk to them, I've accumulated a lot of stuff, and I'm happy to share anything that I have, anything that I've learned to help other people do the same thing. And hats off to Colorado and to Rhode Island for taking it on first. I never even thought about that. I was thinking big picture, OSHA, but nurses have been successful and technicians in every single state that we've done this. It is led by the local people, implemented by the local people, and state law supersedes federal law. So whatever they've got in their state is wonderful to be able to help them institute smoke evacuation and filtration. That's important. Filtration.
Okay, Brenda, this is very inspiring. You hit on all of these themes that we have heard time and time again about having a network, about surrounding yourself with people who can help you, educating yourself on the issue, and then not being afraid to step out and just get started. I mean,
just do it.
That's just where it all begins. And you'd be amazed at all the people that will come alongside you. I know personally, I've experienced your help, Brenda, and from other people at AORN as we try to get something started in Alabama for surgical smoke evacuation legislation, and moving forward in other states as well. When people are looking for that community and that help, it is there and it is available. You just have to look for it. But these conversations go by so much faster than I ever want them to.
Really do. God, I could speak about this for hours.
We have run out of time. But Brenda, thank you. Thank you so much for sharing your expertise with us today and for just joining us. This was very enlightening.
Good. Well, call me if you need anything.
We certainly will. Thank you so much, Brenda. That was Brenda Ulmer, independent perioperative nurse educator, and as I'm sure you can tell from the interview, a very passionate surgical smoke evacuation legislation advocate and just knowledgeable individual when it comes to learning about the dangers of surgical smoke, why we want to avoid it, and how we can actually go about implementing change within our own states. And Chris, I really like that she echoed the same themes that we've heard from everybody else. I know we talked about it already, but you have to have your people, you have to have your network, you have to be educated, and you have to just be willing to get out there and do it and just get started and see what happens. You know, she really, I think, is very inspiring to listen to in that regard.
I agree. And just to hear the collaboration that occurred in Georgia, and I know about some of that journey personally, just because I know some of the people that were involved, and just to hear once again, like all people in the operating room, from the anesthesia providers to the circulating nurses to the surgical technologists and sometimes the surgeons, but to hear that they all work together and combine their voices to make something happen for our profession is just really inspiring. And I hope that our listeners take away from that and do more collaborative things in their states, whether it's surgical smoke regulation or who knows what else is
any other issue that affects the operating room. It's definitely something to think about because just like Brenda said, the nurses, the techs, anesthesia, we are in there every single day. It is what we do. It's our career. And we are in that environment for 8 hours a day, 12 hours a day, 10 hours a day, whatever it may be. And so we really need to be advocating for our health and also for the health of our patients. So that is going to do it for today's episode. And on behalf of Chris and myself and everyone at First Case, thank you for listening to this week's podcast.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.